Okay. I is how much pressure you are pushing into the lungs. So when you do your I and your E, you always make sure that they're 5 apart. The book says you can go 4 apart, but for safety, let's go for 5. Then you always know you have the right amount. Then you have the patient's rate. A usual rate is 16 to 18 on a normal adult. Your I time, always shoot for 1. You're pretty safe going with I. I time drives how fast they're getting their breath, and it also drives what their IE ratio is. Rise time, leave at 3, and the ramp, 90% of the time you're going to leave that off. The only time you use the ramp is if the patient is having hard time acclimating to the machine, especially if it's like a CPAP kind of thing at night only. And what you do is you'll put the time, how long it takes to start from a very low pressure up to the pressure you have set. It's just a time thing. And usually, 20 minutes is probably a good time if you did use it. Then you have your oxygen right here, okay? So if it's a typical BiPAP and it's just somebody, let's say they come in with CHF, if you do a 10/5, a rate of 16, and FiO2, just guide that by your SAT. This would be great settings. But if you have a patient, let's say, who comes in and they have a high CO2 and you really need to get that down, the fastest way to do that is you separate your I and your E more and you up your rate. You never go lower than a 5 EPAP or PEEP. So what would you do? You'd go up. So this patient, let's say, has super high CO2. I would drive this I'd go up to 15, and I would up that rate to at least 20. With this type of setting, and then of course, obviously, the lowest FiO2 possible to keep the SAT where you want it, this will help drive that CO2 down. Now, if you have a patient who let's say, needs, once you get that, activate. Don't ever forget to do activate. Blue. Okay, blue is go. So now remember, this is what you're giving the patient. This is what the patient's giving you. Since we're on that subject, I'll go through it. We got the rate. We got the tidal volume the patient's giving us back. We got their minute volume. We got their peak inspiratory pressure. And this actually should match your IPAP unless the patient is having issues such as they're coughing, the tube is kinked, or they're developing ARDS. Your total leak, that's how much mask leak you got. Now, in a perfect world, you would like to see this 25 or as low as possible. But you really don't want to see it lower than 25 because then your seal is almost too tight. So you strive for 25 and try to get as close to that as you can without going below it. This here tells us how much of the time the patient is triggering the breath. And this is just a ratio. So once you do set your stuff up, the next thing you always should do is set your alarms. When you set your alarms, you got your high and low rate. A low rate, you probably, let's just say 12. Or if the patient's kind of somnolent, you could go higher or lower, but 12 is a really good range. Then you got your high rate, okay? So what is the patient doing? Okay, he's breathing with the machine right now, so that's fine. You could maybe leave it at about 30. That's a good range. When you set your high tidal volume, I always look what the patient is giving us and set that 200 above. So right now that is super, super high right now. So we would turn that way down to, let's say the patient is actually breathing a little deeper here. I'll give them some breaths. But you would bring it down a little bit tighter. So about 200 above, whatever that is. Your low tidal volume, you probably want to, set that within couple hundred of what they're giving you, or even 100, depending how tight you want to watch it and keep an eye on it. Then you look at your high inspiratory pressure. I always leave that at 40 because if that starts to get up like that, I want to know, is this patient going into ARDS? Is he need suctioning? Is he fighting? Why is that going higher than 40? 40 is an awesome range. And as far as your low minute volume, if you're watching your patient closely, you can actually leave that off. Otherwise, you just set it lower than what this number is giving you, just to keep an eye on it, okay? And this one, I always leave at 20. So your other modes, like I said, was CPAP. So CPAP is just oxygenation. It's the same as EPAP or PEEP. A patient then is totally spontaneously breathing. There's no backup rate or anything to drive it. I usually start at about 6 and then go up from there. You watch their saturation. Anytime you're using CPAP, EPAP, or PEEP, always keep an eye on the patient's blood pressure because it can make it drop. So just keep an eye on it. Again, you got your ramp. Here you got C-flex, leave it at 3, and your FiO2 is needed, and you activate it. Now the patient is doing all the work themselves. They're on a CPAP. Okay, so, and again, you adjust your alarms. Anytime you make a vent change, I am gonna go back to this just because then the vent will not alarm for us right now because it will be breathing on with the artificial lung. So that menu we were in before to do the checkout also has brightness of the screen. It has loudness of the alarm. You will never look at vent info. And years ago, we used to use screen lock a lot when we had visitors playing with our equipment. We don't seem to have that issue right now, so we hardly ever use that. So don't worry about it. The other good button that we want to know is standby. Okay, you're going to trial your patient on a different device. Or let's say we're going to try to feed them. Just hit standby, take your patient off, and it'll automatically go into standby for you. There you go. When it's time to put the patient back on, restart, put them back on. Another good button on this machine is your 100% FiO2. Your patient starts looking a little funny or they're having a coughing jag and their oxygen's dropping. Hit that 100% oxygen. It'll run for 2 minutes while you figure out what's going on. If you decide you want to stop it, you can cancel it. Or let's say they're not quite over that hump yet, you can actually extend it by another 2 minutes just by hitting that button. So it's a very nice feature. Another fact I wanted to point out is this is a one-line circuit. This is the circuit the patient has to inhale and exhale out. So therefore, the yellow cap, never close it. I literally take and throw it away when I start it on a patient so nobody accidentally closes it. Also, don't cover it with a blanket. That's their only exhalation port. The other thing is your HME. This is your humidifier. This is the only humidifier on this right now. This needs to be changed daily, okay? Or if it looks like it's got a lot of moisture in it. So that you guys can decide if you want to do that night shift, day shift, and just make sure it gets done. This machine, one of our Bipap machines has a heater on it if we choose to use it. I'm the only one that sets that up. Don't ever worry about it. If it needs to be done, I will take care of it. And at that time, I will report to that nurse exactly how, what to watch for. Basically, we hang a water bag. It's got a self-float, just like what the Airvo or anything else does. It's super easy to deal with, so I will worry about it at that time. Now, we can do inline nebs with this. So there is pictures, always remember, on the side here exactly how this needs to be set up. And when COVID started, we didn't know if we'd need to use it for a pressure ventilator, so I did set it up as such, but it kind of shows you inline nebs or if you'd ever have to use it as a pressure ventilator. We hope we never have to do that. On the back, the picture shows exactly the pieces you need to set this up. It's very easy. Okay, this is for your cannula. You have a T, and you grab another small cup. I'm going to silence it so it doesn't alarm on me while I do this. So now you put that on there. I like to use the hose from the neb because it gives me a little bit more kink, because when you do a neb, you don't want it tipped. You want it straight up and down so it nebs better. And then you got a small cuff on the end. So once you have it like this, I'm going to put this back on my so-called patient so it doesn't alarm. You take your neb, you open the cap, and you push this in. And when you push that in, it opens it up here. You run it off the wall, just like you would do a regular neb. Now, it might drive your pressure up a little and your tidal volume up, so just kind of keep an eye on that. But you just do your neb, otherwise just like normal. But you can see how it would give it a better angle with the hose. You have it in the kit, you might as well use it. When it's done, I do like to take this out, but make sure you cap it because you don't want something more heavy hanging on there if you don't need to. Now when you chart this, You chart it as a non-invasive ventilation, and when you start it on a patient, it's first day, and after that, it's subsequent. And nursing is in charge of charting or charging for that, because I am not here every day, and so it's easier just to leave it as one person. If you start again this in ER, bring that one up and grab the one from second floor and bring it back down. Saves on equipment and not having to dirty another circuit. So when it's time to turn this off and time to clean it, it is the nurse's responsibility to clean the equipment and reset it back up, because I'm not here every day, nor will I always be here, so it's their responsibility. Do not push it back into storage until this has been done. So you take and you turn it off, ventilator shut off. Now, what all gets thrown away? You take all this off, and that is all disposable. You take the gray top wipe everything down top to bottom. Now, I have set up grab bags. It says the Philips V60 Bipap setup. I always have 2 extra ones in ER in their cupboard. I also keep 2 up in the CCU supply room. And if those run out for whatever reason, there's always extra up in the RT supply room. And in that bag is exactly what you need, but not the neb setup, because you do not do nebs on everyone. You got your circuit, you have your bacteria filter, and you have your HME. And remember, if you need to know how this is set up, the picture's on the side, but it is very, very simple to put together. You take your bacteria filter, you take the circuit, it only fits on one way. You take your pressure line, you hook this on here, you put your HME on here and your small cuff, and then I try to keep the little baggie from it, just so I have something hanging over it. If you forget, throw a glove on there or something, just keep the dust out of it. Hopefully there's dust that we don't use it that often. And make sure you put your sign back on there saying the date and your initials, that it was clean. Push it back to where your floor keeps these, and then make sure that you plug it back into the wall so that battery always stays charged. You never know when you might need it for transport.